Let's start with part 4, trauma. Chapter number 22, Introduction to Trauma. Definition of trauma. Trauma originates from the Greek word meaning wound. It implies that a physical force exerted on a person has led to a physical injury. External energy forms and forces that can lead to injury include chemical, thermal, ionizing radiation, and most frequently those of mechanical origin. The degree and severity of trauma sustained can vary substantially and depend upon the magnitude of force exerted. Major trauma denotes injuries to more than one body region and organ system. In the next group of chapters, trauma will be examined from a variety of viewpoints interconnected to different specialities. In this section, we will examine the facets that bind the whole topic together. The magnitude of the problem. Trauma remains the most common cause of death and disability in children and young adults in the resource-rich countries. Globally, approximately 10,000 people die daily as a result of an injury. Road traffic accidents, falls, and intentional violence have been identified as the major vectors of traumatic injury. It is notable that the major burden of injury is increasingly occurring in middle and low-income countries as they industrialize and adopt motorized transportation. In terms of the annual incidence and trends over time, there is variation from country to country. Information is usually obtained from national statistics organizations that use the International Classification of Disease, a system that can be limited in providing accurate descriptions of injury severity. However, the abbreviated injury scale dictionary consists of a greater level of detail, including more than 2000 injury codes, and assigns to every injury a severity score between 1 mild and 6 maximum. This can be submitted into the so-called injury severity score, providing an image of the anatomical severity of injury suffered by the individual patient. Major trauma is defined as an injury severity score greater than 15, which can be written as more than 15. The majority of hospital admissions with injury having low injury severity score ranging between values 4 and 8 and are secondary to single isolated limb fractures and isolated mild head injury. Overall, major trauma affects approximately 15% of all injured patients. The total number of casualties from road traffic accident alone reported to the police in Great Britain during 2015 was 186,189, which was around 4% lower when compared with 2014. Of these, 21,657 people were seriously injured, among whom 1,730 lost their lives, representing a 3% decrease compared with 2014. Across Europe, according to the data presented by the European Transport Safety Council's Performance Index (PIN), it appears that fatalities rose in the majority of countries. Of the 32 countries covered, 21 had an increase in the number of fatalities in 2015, 10 had a decrease, and 1 remained unchanged. Since countries do not use the same definition of serious injury, international comparisons are based on road deaths per million inhabitants. The United Kingdom as a whole had 27.7 deaths per million inhabitants in 2015. The only European countries with a better rate than this is in 2015 were Sweden with 26.6, Malta with 25.6, and Norway with 22.6. The UK and Sweden have been consistently at the head of this table for a number of years. A large proportion of the severely injured survivors experience long-term or permanent disability as a result of their injuries. Almost 30% of them are no longer able to return to their previous occupation, and a great deal of time is lost from work. These individuals end up having profound changes in their lifestyle with long-term pain and suffering. It should be emphasized that an injury not only affects the injured person, but also it affects everyone who is involved in the injured person's life. The impact of the modern epidemic of road traffic accidents on the universal epidemic of violent injury cannot be overstated. The annual direct medical cost of injuries treated in hospitals and additional care facilities is estimated to be around £3.7 billion. Moreover, additional costs due to loss of earnings, loss of productivity, and quality of life damages increase the total sum significantly. While young patients are involved in road traffic accidents characterized by high energy transfer, older patients may sustain injuries from falls, low energy transfer. The most common group to be admitted to hospital in the UK are older patients who have sustained a fragility fracture. Approximately 65,000 to 70,000 patients are admitted annually with proximal femoral fractures, among whom 30% over the age of 65 will die within a year of the incident. Most of the rest will end up having diminished independence and functional capacity. It is therefore no surprise that this particular cohort of patients, which will increase in the coming years owing to the anticipated increase in life expectancy, is thought to represent a huge burden on healthcare services and society in general. In general terms, the vast majority of injuries sustained are not limb-threatening or life-threatening. They are straightforward, and most patients are expected to recover fully and return to their pre-injury status. Nonetheless, the challenge remains to appreciate and diagnose the injuries at an early stage with an awareness of important features that may influence the outcome. For instance, we must be vigilant not to miss non-accidental injury in children and injuries in other age groups related to an underlying disease process rather than the injury itself, for example, pathological fractures. Of note, it has been shown that in 66% of cases when children die as a result of abuse, there has been some previous interaction with a health professional or social services, but the seriousness of the situation was not fully appreciated. Figure 22.1, we can see number of road deaths per million inhabitants of the different countries shown. Of these, the star-marked countries with provisional fatality figures, they have the provisional fatality figures, and the countries with a red outline have fewer than 150 deaths per year, and therefore the fatality rate can vary significantly between the years. Summary box 22.1, trauma, the magnitude of the problem. The vast majority of injuries are not life or limb threatening. Severe trauma continues to be a major cause of death in young patients. Older patients with fragility fractures pose an additional burden to the healthcare system. Look for important features of injuries that could influence the outcome. Management of trauma. From the moment that injury is sustained, every aspect of decision making and management is essential in terms of the survival of the victim. Our initial assessment and concepts of management have specific objectives and are usually based on knowledge acquired over a long period of time in practice. A better understanding of the physiological processes underpinning the host responses to an acute threat to our homeostatic mechanisms, together with protocols formulated to allow clinicians to use standardized measures and to speak a common language, have revolutionized the way we manage patients. All of the above help to reduce delays, particularly when under pressure to make a decision. However, it remains crucial to understand the reasoning as to why we are carrying them out. In trauma, as in other acute conditions, the patient is particularly reliant upon the clinician. A patient with a chronic condition is familiar with the nature of their problem and the way in which it is progressing. The surgeon may offer a remedy and the patient may consider the potential benefits and choose appropriately whether to accept it. The injured patient does not know what will happen without treatment and so relies on their surgeon to inform them of both the natural history and the potential benefits of any intervention. The implication is that as surgeons, we have a duty to be aware of both. The significance of time in the outcome. Injury can occur in the blink of an eye. In the seconds prior to the application of the external injury force or vector, the patient is at their normal baseline, which can be called as the time zero. All subsequent events, including the acute physiological response to injury, the body's internal mechanisms to maintain homeostasis, to compensate for the sequel of trauma, the healing processes, and the actions instigated by health professionals are associated with a timeline. Being familiar with the timeline principle, one should be aware that there is a critical time window in which we can intervene for a positive treatment outcome before the loss of compensatory mechanisms. Moreover, the timeline allows evaluation of any progress made from time zero to other important events and to reflect on whether a specific course of action could have been performed better. Overall, interventions can be distinguished as emergency life-saving, acute restoring hemodynamic stability, and delayed or semi-elective, focusing on the treatment of post-fracture fixation, complications, non-union, infection, and malunion from the orthopedic point of view. It is essential to appreciate that the physiological crisis initiated in the immediate aftermath of trauma will continue to evolve and the risk of mortality is substantial unless the correct and timely interventions are performed. For instance, conditions such as airway obstruction, tension pneumothorax, and hemopericardium can progress very rapidly if left untreated and should be given priority in terms of our initial medical response to the injured patient. Thus, the seriousness and the immediate impact of a specific clinical condition should be prioritized and treated in a systematic approach. What kills first should be managed first. This concept of the hierarchy of medical responses can only be applied and become effective when we are in a position to diagnose early the underlying clinical conditions. Figure 22.2, here we see the estimated time from the incident to death or irretrievable damage for various conditions. So first we have airway obstruction. Immediately after, the time of death is very soon after the time zero. For intra-abdominal bleed, it is a bit more. For extradural hematoma and ischemic limb, we have more time duration to act or to intervene before the death commences. In figure 22.3, diagrammatic representation of the relationship between assessment and response times. In this example, there is time to assess and respond effectively before death. Assessment time is given from the time 0, and then the response time is mentioned. Overall timeline for the generic injury is the topmost horizontal bar. The ATLS, Advanced Trauma Life Support System, delineates an order of priorities set by ABCD, that is, airway, breathing, circulation, and disability, neurology. This hierarchy of priorities is instituted upon the time dependence principle. The clinician should bear in mind that a successful management plan is dependent on, first, the time needed to evaluate and diagnose the nature of the problem, and second, the time taken to respond effectively to the condition discovered. Evaluating and diagnosing a condition can be challenging as the initial clinical signs may be non-specific. The clinical condition will continue to evolve as the time progresses, but by the time the diagnosis has been made, it may be too late to prevent mortality. Taking into consideration the mechanism of the accident and promptly requesting special investigations, for example, computed tomography, the CT, the underlying diagnosis can be made punctually, thus allowing intervention in a timely fashion. A patient presenting following a road traffic, here's an example, a patient presenting following a road traffic accident with a scalp laceration and a reduced Glasgow Coma Scale GCS score of 13 on 15 represents an example of such a scenario where a drop in the GCS could be related to a head injury or to the presence of shock and hypoxia. An injury to the brain can deteriorate with the development of an expanding hematoma, which can be diagnosed with a head CT prior to the presentation of clinical signs. Surgical decompression can be organized speedily, reducing the risk of morbidity and mortality. In this situation, if the time taken to make the diagnosis was prolonged and the clinical signs had presented prior to the treatment intervention, it may be too late to prevent the death of the patient. This clinical case scenario demonstrates the principle that we need to introduce a treatment response even before we have made the definitive diagnosis if we want to save the patient's life. It is clear, therefore, that the timeline concept is critical in the safe management of trauma patients. Reducing the diagnosis time and response time of our interventions is dependent not only on the clinical staff but also on the availability of resources. Recently, the 24/7 availability of the trauma team and the designations of regional hospitals to operate as level 1 trauma centers with availability of all disciplines and appropriate equipment on site has provided the necessary foundation for the development of a unified trauma care system in England. Indeed, the first reports published on its effectiveness in saving lives have been very positive. The timeline concept that has been discussed in the management of patients with multiple trauma can be applied. Summary box 22.2, the importance of time. The timeline concept is an essential component of trauma management. Assessment should be completed within a set time. The time to respond is limited. Both assessment and response should take place in the time window period to irreversible damage or death. Over here, figure 22.4, we can see the diagrammatic representation of the relationship between assessment and response times for extradural hematoma. There are 3 horizontal bars. A is the stages of assessment, which is given. We'll read the A bar. First, starting from time 0, first we can see fracture on imaging can be done, then hematoma on imaging can be seen, several clinical signs are observed, and then clinically it's obvious. In bar B, the components of the response are mentioned. The components of response type are refer, transfer, anesthetize, and decompress. And in bar C, the overall time from incident to death is mentioned. It can be seen that the relying on obvious clinical signs gives insufficient time to respond effectively. So over here, overall timeline for extradural hematoma is given, and finally it leads to death. So I've marked 2 red lines over here. One is when the hematoma is being seen, the left red vertical bar, where hematoma is seen on the imaging. So we get more time till the death. That's the blue horizontal line. Whereas if clinically obvious, if the symptoms are clinically obvious and at that time we diagnose and then do the treatment, then there is not much time before death commences. That's the green horizontal bar. So it's always beneficial to do a scan and get ahead so that treatment can be done and intervention will help to save the life of the patient. The timeline concept that has been discussed in the management of patients with multiple trauma can be applied to patients with isolated injuries. The key issue, irrespective of the time of patient managed with or without multiple injuries, is to reduce unnecessary delays in making the diagnosis and initiating appropriate treatment. Such a global approach would save lives, minimize morbidity, and would make the healthcare system more efficient in terms of resource utilization as well as cost effectiveness. Finally, it should not be forgotten that all clinical conditions are characterized by a dynamic process. This implies that our observations and analysis of the situation can change rapidly, and to an extent that interventions would have to be modified accordingly. Ongoing evaluation of the patient is therefore essential in order to identify and respond to changes noted in a timely fashion. As previously discussed, the initial primary survey applied according to the ATLS protocols in trauma patients should be followed by secondary and tertiary clinical assessment, even after the acute phase of treatment has been completed successfully. Ongoing monitoring of vital organ activity, ordering of the necessary biochemical and radiological investigations, and recording of all the findings in a single place can allow easier evaluation and identification of trends over time to facilitate prompt intervention. Such a strategy may reduce the risk of having undiagnosed injuries and delays in the treatment. A number of studies have been published reporting on missed injuries and making some recommendations on how to avoid this. The timeline following an injury is continuous and the accumulated documentation may become voluminous, complex, and confusing. It is helpful periodically to make the effort to stand back and summarize the situation. The UK National Institute of Health and Care Excellence (NICE) is in their recent trauma guidelines recognized this and advised that a plain language summary of the situation directed at patient's family doctor but intelligible and available to the patient or carer should be made available within 24 hours. Assessment and response. The assessment of trauma. The initial assessment of the trauma patient, besides the clinical examination, should include analysis of the interactions between the patient, the mechanism of injury, and the extent of the injury sustained. Being able to synthesize the interrelationships among these parameters is essential to addressing the pressures of the timeline concept previously discussed. The associations among these three factors are usually very clear but can be hidden. For instance, a 50-year-old male restrained passenger in a car involved in a head-on collision with another vehicle may sustain rib fractures, a sternal fracture, thoracic spine fractures, and possibly cardiac contusion. Abdominal injuries could also be suspected, but overall the clinician knowing the mechanism can proceed quickly to make diagnosis and initiating treatment. However, in cases where no association can be synthesized between the mechanism of the accident and the patient's condition and the clinical signs observed, the reasons behind this picture should be sought. For example, the reported mechanisms may have been underestimated. We will now analyze how the clinicians can make best use of the information available. Summary 22.3, the assessment of trauma. Include the information formula like mechanism plus patient is equal to injury. Look for both obvious and less obvious features. Identify more reasons when the above formula does not make sense. Mechanisms. Mechanisms may be blunt, penetrating, or even combined nature. Blunt trauma can be categorized as direct or indirect and continues to be the most common mechanism. In a direct mechanism, the damage is localized to the site of injury. In contrast, in an indirect mechanism, the damage occurs at a distant site after transmission of the force exerted. For example, a direct kick to the medial aspect of the mid shaft of the tibia in a footballer by an opponent will induce an isolated tibial fracture. Such an injury represents a direct mechanism with bruising and ecchymosis at the area of the force exertion. On the other hand, a fall from a height of 1 meter with a twisting moment at the foot hits the ground can lead to a spiral fracture of the distal tibia. In this situation, the vector of the force was transmitted through the body's tissue to a location some distance away from its original point of application. In this case, other injuries should also be looked for, such as a fibular fracture or even an ipsilateral tibial plateau fracture around the knee joint area. Similarly, a motor vehicle crash associated with the direct trauma of the knee joint of the driver on the dashboard of the car could induce a fracture, dislocation of the acetabulum and hip joint, transmission of the force from the knee joint to the hip socket, and indirect blunt mechanism. Over in Figure 22.5, the injury force of a car accident can be transmitted from the dashboard to the knee and then to the hip, in which the site of injury. Over here we can see the arrows. The injury is on the knee, but it is transmitted towards the acetabulum and the hip. So the dislocation of acetabulum or the fractures of the neck of the femur can happen over here. This is an indirect type of injury. We will see table 22.1, examples and of patterns of injury, the mechanisms, the obvious features, and the covert injuries which can happen with those mechanisms. First mechanism, left-sided impact from road traffic accident. So what are the obvious features? Lateral compression of the pelvis and left-sided pneumothorax can happen. Whereas covert injuries are the splenic rupture and extradural hematoma. Second is flexion distraction, that's the lap belt. Obvious features will be chance fracture of the lumbar spine, dislocated knee, and head injury. Whereas covert injuries include duodenal rupture, popliteal artery disruption, and cervical spine fracture. In electrocution, obvious features are burn on hand and collapse, whereas posterior dislocation of shoulder can also happen as a covert injury. Mechanism, dashboard impact, obvious features, knee wound, covert injuries, posterior dislocation of the hip. The timeline concept previously discussed may or may not be urgent depending on the location and type of injury sustained. For instance, a minimally displaced tibial fracture that a footballer has sustained can be treated satisfactorily for some time after the moment of injury, but in contrast, a fracture of the acetabulum with a hip dislocation, as described above, represents an emergency owing to the potential development of neurovascular complications, damage to sciatic nerve, avascular necrosis of the femoral head. Therefore, the clinician's decision-making process should take into account both the peculiarities of the type of injury sustained and the anatomical location involved. Moreover, it should be appreciated that the conduction of energy in an indirect mechanism, which is transferred via the soft tissues or fluid, can be difficult both to understand and to diagnose accurately and promptly. For example, the rise in pressure secondary to a lower abdominal force could be passed to the vascular tree, aorta, leading to unexpected hemorrhage and death. All in all, one can argue that the effects of direct mechanisms are easier to comprehend than those of indirect ones. Penetrating mechanisms can be divided into those caused by sharp objects and those induced by firearms. With regards to injuries caused by sharp objects, it is necessary to take into account the length of the sharp object, its surface area, and the size of the entry point. The sharp object, for example, a pair of scissors, will cause damage to the underlying tissues that it contacts: skin, subcutaneous fat, fascia, etc. Local examination will confirm the extent of the injury and the need for wound exploration. Being familiar with the relevant anatomy of the area involved allows assessment of the peripheral nerve function and tendon and muscle integrity. Here again, the timeline concept of prompt assessment and response treatment may be crucial in cases where there is vascular injury, compartment syndrome due to internal bleeding, or even joint penetration that could lead to septic arthritis. Knowledge of the anatomical structures at risk is essential to make the right decision in a timely fashion. This is particularly critical for penetrating wounds over the torso, because it is not always easy to establish the track that the sharp object has followed. In this context, it should not be forgotten that the abdominal structures extend higher than anticipated and as high as the level of the fifth rib in expiration. Sharp object injuries, summary box 22.4. Think about the length of the sharp object involved. Knowledge of the local anatomy is essential. Remember that abdominal structures at risk of injury extend high to the chest. Firearm induced penetrating injuries, which are more difficult to comprehend than incisional injuries caused by sharp objects. For instance, a high velocity projectile bullet causes extensive damage to the tissues as it travels, inducing lateral acceleration far from the point of impact and producing either a permanent or a temporary cavity. The importance of the temporary cavity is that it lasts only for milliseconds and usually is not evident during the clinical examination. It is important to be aware that this temporary cavity usually extends far from the boundaries of the apparent injury. Awareness of this phenomenon will ensure that the surgeon carries out sufficient exploration and wound excision. Over here, figure 22.6, we can see a projectile passing through a gelatin block. In A, low energy transfer, and B, high energy transfer. We can see these two gelatin boxes. In A, we can see the bullet is passing with a low energy, and B with a high energy force. And C, the effect of high energy transfer on tissues is shown. Summary 22.5, firearm injuries. High velocity bullets induce permanent and temporary cavitation. Temporary cavitation can contain foreign material. Low velocity bullets induce similar damage to knives. Patient factors. All patients possess a unique profile and medical history and so will react and respond differently to a given traumatic incident. Children and adults of different ages will sustain different injuries as a result of the same mechanism. For instance, a car hitting a pedestrian will induce different injuries in an adult compared with a child. It is important to consider the other aspects of the patient's history. Past medical history, medication and allergy risk will direct not only to the clinical assessment but also to the treatment. Obvious injuries. Some injuries are very obvious and can be identified before details of the mechanisms or patient are known. One can take advantage of this as the presence of an obvious injury can inform and lead to the identification of another which is less obvious. Obvious injuries are usually visible externally. It is therefore no surprise that at the end of the ABCD protocol, there is also an E, referring to exposure and the need to look for other signs of injury. Bruising to the scrotum of a motorcyclist following a collision with a car suggests a pelvic fracture. Contusion over the greater trochanter of the proximal femur in an older patient experiencing difficulty with straight leg raise points to a neck of femur fracture. Finger-shaped bruises on a child's arms and thighs suggest non-accidental injury. The presence of a seatbelt mark on the lower abdomen of a patient involved in a car crash and who has substantial abdominal pain points to damage inside the abdomen. Thus, exposure of the trauma patient should be routine practice in order to avoid missing the obvious. Hidden factors, mechanisms. When analysis of the relationship of the formula mechanism plus patient is equal to injury does not seem to add up, then the hidden information may be contained in the mechanism. Occasionally, it is observed that there has been a deliberate attempt to misinform. While the majority of alert and oriented patients tell the truth, others, in order to protect themselves or others, may fabricate a mechanism. This may mislead the clinician and lead them to look for the wrong pattern of injuries. For instance, a young patient with a calcaneal fracture may report that this was the result of a fall into a hole in the road, when in fact it had occurred during a burglary following a fall from a height of 10 meters. This can delay the accurate diagnosis of the specific injury and may prevent the diagnosis of other important injuries such as a lumbar spine fracture. Although the patient should be given the chance to tell their story, it should not always be believed, particularly if there are inconsistencies. A hidden mechanism can also arise when the patient is unable to give their history of events. For instance, patients who are unconscious, the physically and mentally vulnerable include older patients, perhaps with dementia, and very young children. The difficulty or inability to report the injury is compounded by the fact that it might relate to criminal activity, example, non-accidental injuries. Parameters that should alert the clinician and raise suspicion for non-accidental injuries include external signs of injuries not consistent with the mechanism reported, long bone fractures in a preambulatory child, inconsistent or changing history, aggressive or unusual behavior of carers at interview, posterior rib fractures or posterior rib injuries. It must be emphasized that the clinician, in addition to diagnosis and treatment, must also protect the patient from further harm. This is of paramount importance when dealing with vulnerable individuals, children, and the elderly. If the early signs of abuse are ignored or not taken seriously, it may not be possible to prevent later episodes where serious harm may occur. While non-accidental injuries is a serious issue to address, mechanisms are usually in place and can be followed by passing on the problem to the appropriate team and professionals. Another important issue is the fact that any obvious injuries may provide important evidence regarding the mechanism, which may be important to a criminal investigation. We must endeavor, without compromising treatment, not to affect such evidence by our medical actions, and bear in mind that forensic evidence may be needed for a conviction at a later stage. Furthermore, the importance of is made more apparent if we consider that the victim of an attack may subsequently be a murder victim. Summary box 22.6, hidden mechanisms. The vast majority of conscious patients will tell the truth. Patients involved in criminal activity may not tell the truth. Fear of abuse may prevent vulnerable patients from telling the truth. Clinicians have the responsibility to take actions when the non-accidental injuries is suspected. Over here we can see the figure 22.7, the body proportions at various ages and anatomical locations of injury when hit by a car. So we can see, like, from 1 year to 3 years, 5 years, 10 years, 15 and adult, all these ages, the mechanism, even though the mechanism of injury is same, the amount of damage or the injury or the insult done to the patient will be different because of the difference in the sizes of the patients at the respective ages. Patients, in circumstances where the injury and mechanism are inconsistent, one should consider the possibility that the patient may have an unknown pre-existing condition. For example, an apparent healthy middle-aged woman who bends to lift a box and sustains a fracture at the lower thoracolumbar junction of a spine may have pathological weakness of the vertebral bone, such as advanced osteoporosis. Treatment should not be confined to the local injury but should extend to appropriate investigation and treatment of the underlying fragility of the skeleton, thus reducing the risk of further fracture. Similarly, fractures may be secondary to an undiagnosed or poorly controlled medical condition. For example, a patient presenting with a scalp laceration and a wrist fracture may have fallen as a result of a transient ischemic attack, a hidden patient factor. In this situation, it is essential to include a medical secondary survey to identify the real cause of the injuries sustained and prevent further trauma. Injuries. When analysis of the formula mechanism plus patient is equal to injury has failed to identify a hidden injury, there are two other approaches: the look everywhere approach, the focused exclusion approach. Look everywhere approach. This represents the secondary and tertiary elements of the ATLS system and involves a detailed secondary survey from top to bottom and at different time points soon after the initial treatment phase when measures relating to saving the patient's life have been completed. the day after injury, example during a ward round, or several days after injury, example when the patient first wakes up in the intensive care environment. The implementation of whole body CT, WBCT, scanning the whole body in all major trauma centers has allowed the clinical team to pick up injuries early. Such injuries would have been missed in the past when reliance was made on the initial radiographs of the chest, pelvis, and cervical spine. The threshold for using more whole body CT has been lowered substantially. There is no doubt that whole body CT scan algorithms have been shown to accelerate diagnostic workup, but their effect on survival is controversial. Moreover, concerns have been voiced about the overexposure of patient to radiation with the increasing and often uncritical use of this type of scan. The effective radiation dose to all organs from a single full body CT is 12 to 16 millisieverts. Survivors of the atomic bomb, whose radiation dose ranges from 5 to 100 millisieverts, had a statistically significant increase in the risk of solid cancers. Overall, the risks associated with one scan are relatively modest, approximately 1 in 1250 or 0.08%. However, it has been reported that widespread liberal CT use is responsible for 1.5 to 2% of all cancers in the USA. Of interest, WBCT equates to 76 chest X-rays or 6 months of background radiation. It has been suggested that it should be requested wisely and that developing a triaging protocol can minimize the criticism of its overuse. Focused exclusion approach. This is based on the knowledge that some specific injuries are missed on a remarkable regular basis. Such injury patterns include metatarsal and metacarpal fractures, scaphoid fractures, perilunate dislocations, and posterior shoulder dislocations. When such injuries are suspected, a detailed focus history, clinical examination, and appropriate investigations should be carried out to either confirm or exclude them. Summary box 22.7. Trauma assessment. Knowledge of timelines for important diagnosis is essential. Initial assessment should focus on what kills first. Screen high-risk patients before clinical signs become apparent, as it may be too late to intervene once signs develop. The response to trauma. Completion of the initial assessment according to the formula patient plus mechanism is called to injury should provide the necessary information to formulate and execute a response treatment. During this stage of care, the response to injury will continue to evolve and decompensation may occur unexpectedly. Vigilance is required throughout management to identify the potential exhaustion of reverse mechanisms. The patient's response to injury. From the time of the accident, a cascade of physiological responses will be upregulated to maintain survival. All such responses are part of homeostatic mechanisms that alter with the time elapsed following injury. The timing and nature of interventions should be altered accordingly. Important patient responses that require prompt attention in order to avoid a subsequent negative impact on the patient's hemodynamic condition include the body temperature, oxygenation, and organ perfusion. A decline in body temperature is a frequent finding after injury and may be due to exposure to prevent further reduction in temperature, but also to restore it. Covering the patient with appropriate blankets during transportation, resuscitation, and in the theater environment will minimize the risk of hypothermia, coagulation disturbances, and ongoing bleeding. Patient oxygenation can be optimized with the administration of inspired oxygen or ventilation if needed. Blood loss can give rise to an altered level of consciousness, low blood pressure, reduced perfusion of the extremities, skin discoloration, and tachycardia. By way of response, endogenous clotting factors are activated to stop the bleeding and to maintain adequate circulatory volume. A further consideration is that traumatized lung parenchyma cannot tolerate surplus fluid. Therefore, the latest resuscitation guidelines advocate a reduction in crystalloid administration and the early transfusion of blood products. Furthermore, that is a need to quickly identify and stop the source of bleeding. Another important part of the response to injury is the activation of the immune inflammatory system. Acute phase mediators are released systemically, simulating cellular elements, polymorphonuclear leukocytes, to interact with the endothelium. Under certain circumstances, extravasation of leukocytes may take place with possible autodestruction. Clinical decisions should aim to minimize the risk of an exaggerated immune inflammatory reaction. Surgical procedures, which can act as a second hit when injury is considered the first hit, should be carefully timed and selected. The medical response to injury. Initial management. Where resources are available, the patient found to have sustained serious injuries at the scene of the accident will lead the paramedics to activate the trauma team on call, allowing personnel to await the patient's arrival in the resuscitation room. The team leader, according to the ATLS protocol, will assign trained nurses and doctors to specific tasks. Protective clothing such as gloves and lead aprons is required to protect the personnel from fluids and radiation exposure. Following the ATLS protocol should be a routine process involving experienced team members and ideally avoiding careless delays which may compromise the response time. Potential problems can be predicted. The involvement of the different disciplines in assessing and planning treatment of injuries in different body areas may lead to issues around priority, which can lead to confusion and uncertainty. Who should go first? What investigation should be next? It is the role of the team leader to ensure that this is avoided and that decisions which may be critical for the patient's well-being are executed smoothly. In situations where the system operates according to the local developed protocols, someone should have the responsibility of overruling the protocols if this would be to the best interest of the patient in order to keep the process rolling. Following common pathways to manage patients can save time and reduce errors. The management of hip fractures in older age groups has improved in the UK with the regulated and monitored involvement of surgeons, geriatricians, and anesthetists. However, early labeling can also be misleading and troublesome. For instance, an older female patient with multiple medical problems might, after falling down a step, sustain an ankle fracture and be given the label ankle fracture. Once the label is given, the pathway is set and she may be placed in a plaster of Paris back slab and be admitted for fixation under the care of someone who thinks primarily about mechanical matters. The so-called accidental benign falls may be associated with more severe pathology and injuries. Furthermore, a patient may fall as a result of a medical condition, example a mini stroke, and in addition to an ankle fracture may sustain other injuries including fractures of the pubic ramus and ribs. The wrong label may disguise the seriousness of the injuries sustained and the fact that the patient's condition may rapidly deteriorate, putting their life at risk. The first person in the diagnostic chain has disproportionate responsibility. Early labeling after inappropriate assessment can be incorrect and direct the patient to the wrong care pathway. In general terms, all patients and particularly vulnerable patients should undergo physiological triage to reduce the risk of being wrongly assigned. Beyond the first hour. After the initial assessment and management according to the ATLS protocol and when the endpoints of resuscitation have been accomplished, further interventions are necessary in a patient with multiple injuries. The presence of an open book pelvic fracture, a lumbar spine fracture, a femoral fracture, a liver laceration, and a tarsometatarsal dislocation are examples of outstanding injuries awaiting treatment. The timing of the initiation of fixation, the type of fixation to use, and the priorities of various injuries have been points of discussion for some years. The original work by Bone et al. In the 1980s demonstrating the benefits of early fracture fixation of all injuries led to the acceptance and wide application of the so-called early total care philosophy. This practice became the gold standard of treatment for patients with multiple injuries. However, in some specific patient groups, for example, those with severe chest and or head injuries or those in an extreme physiological state with ongoing bleeding from different sources such as abdomen, pelvis, and chest, it was observed that the ETC concept led to early complications and mortality. Knowledge acquired at the molecular level related to the immune inflammatory response to injury and the concepts of the phenomena of the first hit, the impact exerted on the homeostatic mechanisms as a result of the original trauma sustained, and the second hit, the additional physiological stress induced by surgical procedures, led to the acceptance and implementation of the so-called damage control orthopedics DCO philosophy, which is called damage control surgery DCS in more generalized settings. The stages of damage control orthopedics are resuscitation, hemorrhage control, decompression, decontamination, and fracture splintage. In the damage control orthopedic concept, initially any long bone fractures and the pelvic are temporarily stabilized with the use of external fixators. Definitive stabilization of the fracture, conversion of the external fixators to intramedullary nailing for the femur and plating of the pelvis would take place usually 4 days later when the physiological state of the patient has been stabilized. In contrast, a patient with similar injuries who has stable physiology throughout would be managed with intramedullary nailing of the femoral fracture and plating of the pelvis within the first 24 to 36 hours, the ETC approach. The two strategies of fracture fixation, the ETC and the DCS, are currently practiced on the basis of some specific criteria. The vast majority of the polytrauma patients are suitable for ETC, 80 to 90%. Specific criteria are shown in table 22.2. Over here we can see the difference criteria for damage control surgery and early total care surgery. The criteria for DCS will hypothermia less than 34 degrees Celsius, acidosis less than a pH less than 7.2, serum lactate more than 5 millimole per liter, coagulopathy, blood pressure less than 70 mmHg, transfusion approaching 15 units, and severe injury severity score more than 36. These suggest that the patient is hemodynamically not stable, therefore we have to go forward with damage control surgery. Whereas in criteria for the early total care includes stable hemodynamics, no need for vasoactive or inotropic stimulation, no hypoxemia, no hypercapnia, serum lactate less than 2 millimole per liter, normal coagulation, normothermia, and urinary output more than 1 ml per kg per hour. It is important for the clinician to appreciate that the physiology of the patient can change rapidly. Patients with a high injury severity score, the so-called patient at risk, can decompensate quickly. Ongoing evaluation of the patient is therefore paramount to allow the clinician to choose the right strategy for the right patient. The early total care and damage control surgery should complement rather than compete with each other. The decision regarding who should go first, what is to be fixed first, and with what type of implant is most of the time straightforward. Nonetheless, the clinician should always be prepared for the unexpected and have a bail-out solution ready to be implemented. Consequently, a plan should always be made available to the trauma team to inform them about the details of treatment, particularly in the operating room environment. The plan can be recorded on a whiteboard with clear guidance on the alternative pathway to be implemented should the patient's condition deteriorate. Ongoing monitoring of such parameters such as core temperature, lactate, base, excess, coagulation, etc. will give knowledge of the patient's condition at any time point during care. Appropriate decisions can then be taken to ensure that the safety of the patient has not been compromised. For instance, if the early total care concept has been applied and the polytrauma patient with a head injury and chest trauma is on the operating table, awaiting to have a femoral fracture stabilized with intramedullary narrowing, and the condition deteriorates, the early total care plan can be changed to DCO. An external fixator can be applied quickly to stabilize the femoral fracture temporarily. This allows prompt transfer of the patients to the intensive care unit where resuscitation can continue within a safe environment with ongoing monitoring of vital organ functions, lungs and brain. When injuries involve the input of different disciplines in terms of surgical intervention, for instance, a general surgeon for a liver laceration, a neurosurgeon for an intracranial hematoma, an orthopedic surgeon for a pelvic and femoral fracture, and a maxillofacial surgeon for a depressed orbital fracture, the most important intervention should go first. Clearly, communication and prioritization among the team members is essential. As each procedure nears its completion, communication with the anesthetist will allow a decision as to whether it is safe to go on to the next procedure. Note, infrequently and assuming that it is technically possible, two teams can work simultaneously to significantly shorten the time the patient will spend in the operating theatre environment and allow subsequent prompt transfer to the ICU for optimization and ongoing monitoring. Local protocols and guidelines. While the ATLS protocol has become the standard of care for the initial management of patients with multiple injuries, other protocols and guidelines have also been developed to allow the treatment of patients in a more standardized way. It is not uncommon for each trauma center to develop its own local guidelines, although national guidelines may also exist. Regional guidelines may refer to smaller areas of practice such as antibiotic prophylaxis for open fractures, mass transfusion, pharmacotherapy for coagulation disturbances, steroids for spinal cord injuries, clearance of the cervical spine, and angiographic embolization of pelvic fractures. These protocols can facilitate quicker decision making, eliminating delays and benefiting the patient. They also protect the clinician and care provider with regard to medical legal issues. An example referring to the angiographic embolization of pelvic fractures is shown in figure 22.8. Local policies focusing on the creation of single charts facilitating daily input of patients' vital signs and biochemical results are useful in allowing sequential observation of the results, which can demonstrate more important trends. These trends can be useful in identifying early clinical condition which can be treated within the time frame concept and prior to the establishment of irreversible damage to the affected organ, at which point any form of intervention will be meaningless. For instance, the clinical evaluation of respiratory insufficiency in an individual without pre-existing lung disease secondary to pulmonary embolism is easier to identify by evaluating the trend in the oxygen saturation of inspired oxygen. Over here, figure 22.8, pelvic fracture angiography protocol. First, it stands stable, left side above, stable response to the initial resuscitation, and then unstable patient move to the theatre, and stabilization of the pelvis and pelvic packing is done. It is then taken for CT scanning. If the patient is stable, directly CT scanning is done. If there is no arterial blush, then again stabilization of pelvis and pelvic packing is done. If there is arterial blush, embolization is done. Again stabilization of the pelvis and pelvic packing is done. This is the protocol for pelvic fracture angiography. Planning and individual operation. Operative procedures in a polytrauma patient struggling for survival are critical in the acute phase. Their outcome can affect morbidity and mortality. For this reason, it is essential to get it right the first time. It is therefore also essential that there is adequate study of the problem to be solved, followed by the appropriate planning and execution, analyzing the fracture pattern and deciding about patient positioning, the surgical approach to be used to get adequate access to the bone for reduction, the type of implant to be used, the correct positioning of the implant, the soft handling, tissue handling, and the type of rehabilitation are just some of the parameters of the consideration. Summary box 22.8, the response to trauma. Rationalize patient management with development of protocols and guidelines. Avoid unnecessary delays. Observe trends and identify promptly evolving conditions. The surgeon should answer questions such as, is it the optimum time to carry out the procedure? Am I the most appropriate person to carry out the procedure? Have I made a contingency plan should the procedure become difficult to complete? What is my plan A, B, or C so I am able to successfully finish the procedure? Recording all the important issues on a piece of paper or suitable alternative will ensure that no parameter of importance will be left out of the planning. In order that the procedure runs smoothly in theatre, documentation of the plan can be made on the whiteboard. Such a practice will allow every member of the surgical team to be aware of the potential issues to be addressed and the plan of action that has been decided. The appropriate surgical equipment for plans A, B, and C can be clearly identified and kept in close proximity to the operating theatre. The above strategy will eliminate unnecessary detail and ensure that there will be no surprises, for instance, required equipment found to be unavailable. The response to the mechanism of injury. Before that, we'll see summary box 22.9. Planning and individual operation. Adequate preoperative planning is essential to eliminate unnecessary delays. Document the plan to ensure no important parameter is left out. A whiteboard can be used to demonstrate the order of plan execution and act as means of communication with staff. The response to the mechanism of injury prevention. Not infrequently, patients are seen who have been injured at the same geographical area with the same mechanism. A possible case scenario is that over a period of few weeks, several patients are noted to present with a fall of 2 to 3 meters in the same location from a particular bridge. Further investigation might establish that the bridge is easy to access, perhaps because of damage to safety measures. With appropriate steps, the damage can be rectified and the access to the bridge limited, preventing further harm. In this example, the surgeon is involved in both the treatment and the prevention of injury. Therefore, when a mechanism of injury becomes more frequent and is associated with serious life-threatening trauma, it is essential to take steps either to eliminate the mechanism or to lessen the consequences. The issue of injury prevention is not only an important consideration for clinicians, but also for other stakeholders. For example, politicians developing appropriate legislations relevant to road safety, manufacturers optimizing the safety of cars, and the construction industry. This accounts for the improvements in safety that can be achieved. Summary 22.10. Response of the mechanism of injury. Be alert to identify frequent patterns of injury. Many stakeholders, including clinicians, should engage in injury prevention. Legislation and education are essential. The response to patient factors. Injuries presenting with increased frequency in an individual patient require special attention. Older patients, perhaps with multiple medical problems, and can represent such a vulnerable group. The reduced bone mineral density making the skeleton fragile is associated with an increased risk of fracture. Hip fractures, wrist fractures, spinal fractures, and pelvic fractures are just some of the many results following minimal trauma. The risk of fracture is increased with the presence of comorbidities such as visual impairment, Parkinsonism, or transient ischemic heart attacks. Consequently, knowing the parameters associated with a particular group of patients, attempts can be made to reduce the number of patients requiring treatment. For instance, prescription of bone protection therapy and addressing early the medical comorbidities, example cataract surgery, may help to reduce the number and severity of injuries sustained. Development of specific guidelines and protocols can facilitate the much needed implementation of unified measures, allowing easy patient access and treatment. Summary box 22.11. Response to patient factors. Older patients may be vulnerable to injury owing to poor bone stock and other comorbidities. Bone protection treatment is essential. Development of local and national guidelines to respond to patient factors is desirable. Conclusion. Trauma can affect all patient age groups. The severity of injury depends on the type and nature of the mechanical force applied. The formula patient plus mechanism is equal to injury should be kept in mind when dealing with trauma patients. There is a connection among the three components of the formula, all of which should fit together in a coherent way. When no relationship can be made, examine for pre-existing pathology and hidden injuries, or consider whether the history given by the patient is at fault, including deliberate attempts to mislead. Be aware of the timeline concept because there is a minimum response time to initiate and complete treatment in order to deal with a specific condition successfully. Early assessment and management of patients with multiple injuries is carried out using the ATLS protocol and other guidelines developed either locally or at national level. Subsequent treatments for definitive stabilization can be personalized by one of the two of the existing fracture fixation strategies, the early total care or the damage control orthopedics. Specific criteria can assist the clinician to make the right decision for the right patient. Different groups of patients, such as the older patients and children, have different demands and should be managed accordingly. While we as clinicians are focusing on treating the injury sustained, we have other responsibilities, including our active involvement in preventive measures. Preventive measures should be commissioned when particular mechanisms can be identified as being common or important causes of injury. Summary box 22.12. Conclusion. Look for hidden injuries. Remember the timeline concept. Specific criteria will decide the fixation strategy, either early total care or the damage control orthopedics. Thank you.